Hello, everyone. This is Dr. Mickey recording a lecture on Chapter 13, which is the medications or drugs, agents called adrenergic drugs affecting the ANS, autonomic nervous system. So these are medications that are going to interact with alpha and beta receptors, and we have different alpha and different beta receptors, and we'll describe each and every one of these alpha and beta receptors as we explain the content in the subsequent or upcoming slides. So the norepinephrine. So the first slide explains about norepinephrine. I believe that also in chapter 12, I went over and explained the life cycle of the dopamine and the norepinephrine neurotransmitter, and the norepinephrine that is released by most of the postganglionic nerves, and we call these agents, or the norepi and epinephrine, they are called catecholamines. Catecholamines, norepi and epinephrine. So they're natural or synthetic. So the natural catecholamines like epinephrine, norepinephrine, which is epinephrine, which is adrenaline, and the norepinephrine, and the third one is the dopamine. So we have norepi and epinephrine, which is adrenaline, and the dopamine. And they are usually released by the adrenal glands. And then we have synthetic medication, which is catecholamines, which is a synthetic epinephrine. It's a medication that we administer in certain scenarios, and I will explain, the indications for these medications. Like dopamine, also dobutamine, isoproterenol, the all synthetic catecholamines. So two types of adrenergic receptors. We have the alpha receptors and beta receptors. So the most important part of the pharmacology is based on the interaction of these agents or medications with alpha or beta receptors. So we have alpha-1 adrenergic receptors that will be found in almost all sympathetic target organs except the heart. So the response would be constriction of blood vessels. So the alpha-1 adrenergic receptors, the response to the activation would be constriction of blood vessels, which will result in increased blood pressure, dilatation of pupils, which is mydriasis, so the alpha-1 adrenergic receptors at the presynaptic adrenergic neuron terminals that are found, and it inhibits the release of the norepinephrine. The beta-2 adrenergic receptors, they are found in all sympathetic target organs except the heart, and they inhibit smooth muscle. So there are 5 mechanisms by which the drugs can affect the synaptic transmission. They affect the synthesis of the neurotransmitter in the nerve terminal. So it has an effect on the synthesis of this neurotransmitter, or it will prevent the storage of the neurotransmitter in vesicles within the presynaptic nerve. The third mechanism to influence the release of the neurotransmitter from the presynaptic nerve. The fourth one is to prevent the normal destruction of reuptake of the neurotransmitter. And the last one, the fifth one, is to bind to the receptor site on the postsynaptic target tissue. So if we look at how the dopa and then, or even phenylalanine, tyrosine becomes dopa, and then dopamine, and then dopamine will be converted or becomes it's a precursor for the norepinephrine, and how norepinephrine will be in its In the presynaptic now nerve, it will be released into the synaptic cleft, and then it will bind to the alpha or beta receptor. So the norepinephrine, it may disintegrate. So the life cycle, we went over life cycle in chapter 12, and the five different mechanisms by which the drug can affect the synaptic transmission. In this case, like it's norepinephrine, for example. The first function or mechanism would be to affect the synthesis of this neurotransmitter in the nerve terminal. So let's just define this instead of a neurotransmitter. Anyone will, we'll talk about norepinephrine here. So it will affect the synthesis of the norepinephrine in the nerve terminal, which is a presynaptic, or prevent the storage of the norepinephrine in the vesicles within the presynaptic nerve. The third mechanism to influence the release of the norepinephrine from the presynaptic nerve. Fourth mechanism is to prevent the normal destruction or reuptake of the norepinephrine. And the norepi, it's one of the steps in terms of life cycle is that the norepi goes back into the vesicle in a form of reuptaken into the presynaptic nerve, and that reuptake of the norepinephrine becomes the converted now in the presynaptic nerve to EMAO, which is E-monoamine oxidase, and become an active product after that. It's the norepi is no more active or no longer active because it has been converted from norepinephrine into the monoamine oxidase, which is MAO. And the last mechanism is to bind to the receptor site on the postsynaptic target tissue, which is that the norepinephrine is going to bind to either the alpha or the beta receptor in the post-junction or postsynaptic target tissue. In other words, it's the post-junctional cell, the receptor on the post-junctional cell, which is postsynaptic target tissue. These are the 5 different mechanisms by which the drugs can affect the synaptic transmission. Let me provide here an example of norepinephrine. So these are different types of receptors in which the neurotransmitter like norepinephrine will bind to alpha 1, alpha 2, beta 1, beta 2, or even beta 3. The primary location of each receptor where it's located, and then the response when the norepinephrine will bind to these receptors. So norepi binds to alpha 1 will result in constriction of blood vessels, vasoconstriction, and dilatation of pupils, mydriasis. Alpha 2, norepinephrine, when it binds to alpha 2 receptor, it will result in inhibition of the release of the norepinephrine. So less norepi will be released from the presynaptic nerve. When norepi binds to beta 1, which is most common sites or primary locations will be the heart and kidneys. So that's the norepi binds to beta 1 at the heart and kidney. That will result in tachycardia, increased heart rate, pulse, and increased force of contraction. Contractility of the myocardium will increase, and the release of renin. When norepi binds to beta 2 receptors at the the sympathetic target organs except the heart, then this binding of norepi to the beta 2 will result in inhibition of smooth muscle. When norepi binds to the beta 3 in adipose tissue, urinary bladder that result in lipolysis and relaxation of the detrusor muscle. In other words, that will increase the urination. That will allow urine to exit the bladder. This is a difference between catecholamines and non-catecholamines. So the catecholamines, we said, like, epi and norepinephrine or dopamine. So they are only available as an IV use only. So you'll find them as an IV drug. And it's a short acting, like epi, norepi, isoproterenol, dopamine, dobutamine. These are short acting drugs, and it's only IV. And shouldn't be given orally and cannot be given. It's only available as an IV drug use. The non-catecholamines, same thing, cannot be given orally, metabolized slowly by the monoamine oxidase. They have a longer half-life, and they are more able to cross the blood-brain barrier than the catecholamines. Catecholamines cannot cross the blood-brain barrier. But non-catecholamines, they have more ability to cross the blood-brain barrier. And we have examples like ephedrine, phenylephrine, terbutaline. So we have three neurotransmitters like the acetylcholine, norepinephrine, and epinephrine. So the epinephrine will activate receptors alpha and beta, all of them. So epinephrine is able to activate all alpha and beta receptors, all of them. The norepinephrine can only activate alpha 1, alpha 2, and beta 1 receptors. The dopamine can activate alpha 1, beta 1, and dopamine receptors. So for example, so this is there will be a table I will share in class, a table that, that will provide more explanation about the different types of neurotransmitter and the different or specific receptors that each one of these neurotransmitters will activate: epi, norepi, and dopamine, and what would each one of these neurotransmitters will activate in terms of alpha or beta receptors. Now, mechanisms of adrenergic receptor activation. Receptor activation. So either it's a direct receptor binding, the drug going to bind directly to the receptor. So that will be all drugs in this chapter will be of this type, which is a peripheral effect. Peripheral effect. So it mimics, it will mimic the actions of natural neurotransmitters. So the drugs or medications, they will mimic provide exactly identical activation effect or mechanism as norepinephrine, epinephrine, or dopamine. So it's medications that are going to synthetically produced to directly activate the receptor by binding to the receptor. The indirect acting of these adrenergic drugs or agonists, it will be either by promoting the norepi release, like the amphetamines, ephedrine, that works exactly within this mechanism. It promotes the norepinephrine release, the amphetamines, for example. Inhibition of norepinephrine reuptake. Prevent that norepi to be reuptaken to the presynaptic nerve like cocaine, TCAs, which is tricyclic antidepressant medications. They inhibit the norepinephrine reuptake. The last one or type of or mechanism of the adrenergic medications, they inhibit the norepinephrine inactivation, like monoamine oxidase, MAO inhibitors. Monoamine oxidase inhibitors, MAO inhibitors, they inhibit the norepinephrine inactivation. So it will maintain the norepinephrine in its active form, because it will inhibit its inactivation. Because when it's becoming activated or becoming active, it will be converted from norepi into now monoamine oxidase to become inactive. So these are the MAO inhibitors. They work within that mechanism, which is the inhibition of the norepinephrine inactivation. Prevent the inactivation of the norepinephrine. Inhibit the inactivation of the norepinephrine, such as the MAO inhibitors, which are will be covered in psych mental health course. So, two related notes from the mechanisms of different adrenergic drugs. In direct acting adrenergic agonists, which is belong to number 2, 3, and 4, they will lead to or they will affect the central nervous system. So are going to affect the CNS and may result in hypertension and dysrhythmias. That's from the indirect acting adrenergic agonists. It will affect the CNS and may lead to hypertension and dysrhythmias. What are the therapeutic applications and adverse effects of the adrenergic receptor activation? So therapeutic activation or applications of the alpha-1 activation. What kind of indications or diseases or conditions that might be treated or can be treated within this mechanism? Hemostasis. We can stop the bleeding by doing or eliciting or causing this vasoconstriction. We can arrest bleeding or stop bleeding via vasoconstriction. Nasal congestion. We can, through the mucosal vasoconstriction, we can prevent the congestion like phenylephrine, ephedrine, either it's PO or topical, like phenylephrine topical and ephedrine oral. The third one is adjunct to local anesthesia. We can inject or mix the local anesthesia like lidocaine with epinephrine, so we can delay the absorption of local anesthetic like lidocaine. So we can prolong the effect of the anesthetic medication if we mix it with epinephrine, because epinephrine is a vasoconstrictor. It results in vasoconstriction local at the local site, so the affected area in which the lidocaine is being injected for local procedure. So the vasoconstriction, which has resulted from that epinephrine, it will delay the absorption and prolong the effect of the local anesthetic like lidocaine. The fourth one, which is the elevation of blood pressure. So when there is a hypotension, these drugs can increase blood pressure by eliciting this or via the vasoconstriction. Mydriasis, which is dilatation of pupils, which might be, required or needed during the ophthalmic or eye exam. So the adverse effects of the alpha-1 activation would be hypertension from the widespread vasoconstriction, necrosis, which could or may result or caused by extravasation, which is the leakage of medications in the outside the blood vessels. And these, so this necrosis will be caused by extravasation, which is secondary to IV use of alpha-1 agonists. So whenever we are using the alpha-1 agonist, so we anticipate the extravasation, which is the leakage of drugs outside the blood vessels to adjacent sub-Q or adipose tissue, which can be corrosive or result in necrotic tissue. So the treatment for this would be alpha-1 blocking agent. So the alpha-1 agonist will result in extravasation and necrosis. Then the treatment for this would be to administer a drug called phentolamine, 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 which is the alpha-1 blocking agent. So it's an alpha-1 inhibitor to treat the extravasation, which has resulted from the alpha-1 agonist. The last one, which is the adverse effect of alpha-1 activation, would be bradycardia, which is a response to the vasoconstriction and elevated blood pressure. So the baroreceptor reflex, in which that there will be bradycardia in response to the vasoconstriction and elevated blood pressure. Therapeutic application, clinical consequences of alpha-2 applications, so activation. So we already had discussed or went over the therapeutic applications of alpha-1 activation, and now the clinical consequences of alpha-2 activation. So the alpha-2 receptors and periphery, so they're located in the presynaptic. So the activation will inhibit the norepinephrine release. So alpha-2 receptor in the periphery, the activation will result, but will inhibit the norepinephrine release. The alpha-2 in the central nervous system, in the CNS, so reduction of the sympathetic outflow to the heart and blood vessels, relief of severe pain. So the alpha-2 receptor activation results in inhibition of the norepinephrine release. Therapeutic applications of beta-1 activation. So beta-1 receptors can be activated by epi as a propranolol, dopamine, dobutamine, ephedrine. So it can treat patients with cardiac arrest. So it's not the preferred drug of choice, but it can affect, it can benefit from cardiac arrest. So the epinephrine directly injected to the heart to treat cardiac arrest. Heart failure. So we can use positive inotropic medications. Inotropic effect, which pertains to or is caused by, or we can define the inotropic effect by the strength of contraction. So positive, which means increased strength of contraction or contractility of the myocardium, that becomes the positive inotropic effect. So this can treat patients in heart failure by increasing the contractility and the force of contraction of the myocardium. In shock also, beta-1 activation, it will be effective in patients with shock because of positive inotropic effect, the same effect we explained in heart failure too. Positive inotropic effect. It will result in increased heart rate, increased cardiac output. Also, patients with AV heart block, because it will enhance the impulse conduction through the AV node. So what type of adverse effects we anticipate from beta-1 activation? Adverse effects from the beta-1 activation would be altered heart rate or rhythm. Otherwise, in other words, is like tachycardia, dysrhythmias. Second, angina pectoris. So that will result from the increased cardiac oxygen demand. There is high demand when the heart rate, increases, when the contractility increases, so this requires more oxygenation. So the increased cardiac oxygen demand will result in what is called the angina pectoris and chest pain. So remember that also, and we just write a note here, is that the beta 1 receptor affect both heart and kidneys. Now, the beta 2 receptors, which affect the lungs and uterus, epinephrine, ephedrine, isoproterenol, trobutalin. So therapeutic application of beta 2 activation. So when the drug activate beta 2, that can be medications for asthma, like inhalation therapy. To also can treat for a delay of a preterm labor. And the adverse effects of beta 2 activation would be hyperglycemia, and that's from the enhanced glycogenolysis, when there is an increased rate of conversion of the glycogen in the liver, stored glycogen into glucose, so for source of energy, that becomes result in hyperglycemia. So the hyperglycemia here from the beta 2 activation, it's from the enhanced glycogenolysis. And that occurs in patients with diabetes mellitus. Second is tremor, and that's enhanced skeletal muscle contraction. Turbulin, selective for beta 2 receptors. Dopamine, clinical consequences of dopamine receptor activation. So activation of the peripheral dopamine receptors causes dilatation of the vasculature of the kidneys. So it will result in more kidney perfusion, in other words. So the kidney perfusion will be enhanced. And dopamine would be the only medication that activates dopamine receptors. So it can be, dopamine can treat patients with shock. It may activate also beta 1 receptors to enhance cardiac performance. So the classification and naming of the adrenergic agents, in which that we will compare between the adrenergic agonists and the antagonists, like inhibitors. So for the adrenergic agents, or the stimulation, first of all, the stimulation versus inhibition. The stimulation of the sympathetic nervous system result in, or these drugs are called adrenergic agents. The inhibition of the sympathetic nervous system drugs or medications are called adrenergic blocking agents or inhibitors or antagonists. So the prototype drug for the adrenergic agents is the phenylephrine or neosynephrine, which is to stimulate the sympathetic nervous system either directly or indirectly. it will, its primary use, if it's alpha 1 or alpha 2, beta 1 or beta 2. So it depends on the effect of the drug on which receptor, and that will be will result in a different um, mechanism, or the indication will be different. So, for example, alpha 1 receptor activation, the drug that which activates the alpha 1 receptor will result in nasal congestion, hypotension, dilation of pupils for eye examination. So these are resultant, or in other words, that you can call it indications. So the primary use for alpha 1 receptors, it's effective for nasal congestion. Alpha 1 receptors also, the activation it's good for hypotension because it results in vasoconstriction. Alpha 2 receptor activation results, it's effective for hypertension. Beta 1 receptors are effective for cardiac arrest, heart failure, shock. Beta 2 receptors activation, it's effective for asthma, premature labor and contractions. So here we have different medications and with associated primary use. Albuterol, for example. It's a beta 2 agonist, and it's very effective for asthma, COPD. Clonidine, it's an alpha 2 agonist, but it's centrally alpha 2 receptor agonist, because that's alpha 2 in the CNS. So clonidine is centrally acting alpha 2 receptor agonist, and it's very effective in hypertension, ADHD, pain management. Dobutamine, it's a very effective drug. Dobutamine, it's a beta 1 agonist. It's very effective for cardiac as a cardiac stimulant to increase cardiac contractility. And so that's dobutamine, sorry. And then the dopamine, which is an alpha 1 and beta 1 receptor agonist, effective in shock. Ephedrine, which is alpha and beta receptor agonist. So an ephedrine and then isoproterenol. So so we have the medications, the drugs, and which receptor is going to be activating, and resultant effect. In other words, we know the primary use for the specific drug. We have another set of medications like methyldopa, Alderman, with some alpha 2, and it's another centrally acting drug, like clonidine in the previous slide. Clonidine and methyldopa, they are both are alpha 2 and CNS agonists. So alpha 2 agonist, centrally acting alpha 2 agonist, and both are effective drugs for hypertension. Midodrine, it's an alpha 1 agonist. It's effective for hypotension. And I will explain in class the indications for the use of midodrine. Chromatin, or midodrine, the generic name. It's an alpha 1 agonist. The norepinephrine, Levophed, it's an alpha and beta 1 agonist. It's effective for shock. Phenylephrine or niacin, it's an alpha agonist. It's effective in hypotension and nasal congestion. It's the nasal decongestant. Pseudoephedrine, it's an alpha, like Sudafed, for example, it's over-the-counter Sudafed. Pseudoephedrine, like Sudafed, is an alpha and beta receptor agonist, and it's very effective in nasal congestion. So because these medications, they are vasoconstrictive, so it's should be discussed with the prescriber for patients who have or with a history of hypertension, because these are vasoconstrictive medications. Trobutalin, It's a beta 2, as salmeterol also it's a beta 2 agonist. So beta 2 agonists are good for patients with asthma, COPD. They are breathing treatments. So the um, neosynephrine. Well, first of all, before we move on, the methyl dopa or aldamate, it causes hepatotoxicity. It's a serious adverse effect of methyl dopa, hepatotoxicity. Clonidine, on the previous, also one of the previous slides, clonidine, um, it has 3 approved uses, which is treatment of ADHD, hypertension, severe pain. Also, it has one of the most common side effects is xerostomia, XEROSTOMIA, which is dry mouth. Xerostomia or dry mouth. It's one of the common side effects from clonidine. So the prototype drug for the adrenergic agonist, which is sympathomimetics, adrenergic agonists or agents, the phenylephrine or neosynephrine, it's effective for nasal congestion, to cause mydriasis, pupil dilatation, and it's antihypotensive. In other words, that it's to treat hypotension because that's due to the vasoconstriction. It will increase blood pressure. So the adverse effects, the ophthalmic preparations can cause the eye medication or the drug form in it's like an eye drops. Um, it can cause narrow angle glaucoma because they have a mydriatic effect, which is pupil dilatation. So it may cause glaucoma. And high doses can cause reflex bradycardia. And that's due to the elevation of blood pressure caused by stimulation of alpha-1 receptor. In other words, that vasoconstriction has resulted in an increased blood pressure and then reflex bradycardia, decreased heart rate. Interactions, drug interacts with a MAO inhibitors, causing hypertensive crises. Increased effect can also occur with the TCAs, tricyclic antidepressants, ergo alkaloids, and oxytocin. And the inhibitory effects occurs with the alpha blockers and the beta blockers. The treatment of overdose. Overdose may cause the tachycardia and hypertension, and the treatment usually it's with the alpha blocker or inhibitor, like alpha inhibitor or blocker, such as phentylamine, which is the brand name is called Regitine, Regitine. Phentylamine, which is the generic drug name, which is the Phentolamine, phentylamine. So the treatment again for the overdose with the phenylephrine is usually treated with alpha blocker, such as phentylamine or Regitine. So it may be indicated to decrease the blood pressure. So the epinephrine or adrenaline therapeutic uses, we have alpha 1, like delayed absorption of local anesthetic, control superficial bleeding, elevate blood pressure. Because remember that alpha 1 agonist is going to increase, like epinephrine is going to increase blood pressure, vasoconstriction, or mydriasis during ophthalmic procedures. Delay absorption of local anesthetic, control superficial bleeding, elevate blood pressure, mydriasis, which is pupil dilatation during ophthalmic procedures. The beta 1 overcome AV block. So to treat the AV block, restore cardiac function and cardiac arrest. Therapeutic uses for beta 2, like patients with asthma, beta 2. So if that's a beta 2 agonist, then patients with asthma, because that results in bronchial dilatation in asthma. So patients with asthma will benefit from beta 2 agonist. And also it's a treatment of choice for anaphylactic shock. So after sub-Q injection, it will be absorbed slowly, which is secondary to vasoconstriction. It's only available as topical or injection. Adverse effect, hypertensive crisis, dysrhythmias, angina pectoris, necrosis following extravasation of the drug from the blood vessels into the adjacent tissues and sub-Q tissues. And the treatment for this extravasation will be phentylamine, which is the Regitine, which is an alpha blocker, or alpha inhibitor, or alpha antagonist. And another side effect would be hyperglycemia. The drug interaction with the epinephrine adrenaline would be MAO inhibitors, TCAs, tricyclic antidepressants, because they will, the TCAs, the tricyclic antidepressants, they block the epinephrine reuptake. They block the epinephrine reuptake. That's their mechanism of action. That's how the TCAs, tricyclic antidepressants, work. So the MAOs and TCAs prolong the intensity of the epinephrine because they either inhibit the MAO or block the epinephrine reuptake. Then general anesthetics, drug interaction with general anesthesia, causing tachyarrhythmias. drug interaction with alpha adrenergic blocking agents, like what um, we just have went over this, or mentioned the phentylamine, rigidine, as an alpha blocker. Beta adrenergic blocking agents, or beta blockers, like um, metoprolol or propranolol. Norepinephrine, like Levophed, is specific to alpha 1, alpha 2, and beta 1 receptors. It's very effective for hypotensive patients, patients who had developed or sustained cardiac arrest. Norepinephrine or Levophed is very effective for hypotension because it will increase blood pressure and in cardiac arrest. And how it's different from the epinephrine, it doesn't activate beta 2 receptors. That's how it's different from the epinephrine. So it does not promote hyperglycemia. So epinephrine will promote hyperglycemia because it will activate the beta 2 receptor. The norepinephrine, which is Levophed, it doesn't activate beta 2 receptor, so it will not promote or increase or result in hyperglycemia. Isoproterenol, which is isoprel, receptor specificity. So this drug is specific to the alpha 1, alpha 2, and beta 2 receptors. Isoprel is only specific to the beta 1 and beta 2. So um, the ephedrine is the one that is uh, specific to the alpha 1, alpha 2, and beta 2. It's called ephedrine. But the isoprel only beta 1 and beta 2. So the isoprel, it's only specific to the beta 1 and beta 2 receptors. And it's very effective in for different indications like cardiovascular, for the AV block, cardiac arrest, in asthma, patients with asthma, because it will result in bronchodilation. But it's because of the advent of the new effective uh, uh, breathing treatment drugs. This drug is not used anymore for asthma. And bronchospasm, that's during anesthesia. It can be effective during anesthesia if patient develop the bronchospasm. But again, it's heavily isoprel or isoprel is really cardiovascular indications only. So the adverse effects, it's less than or fewer than those of norepi or epinephrine, because the drug, the isoprel, it doesn't activate the alpha receptors, only beta 1 and beta 2. It can also, the adverse effects can be result in or lead to tachydysrhythmias and angina pectoris, hyperglycemia in patients, diabetic patients. Drug may interact with MAO inhibitors, tricyclic antidepressants, and beta blockers. Dopamine, specific to dopamine receptors at 3 different levels or doses, it will produce a different effect or specific effect. Like at low therapeutic doses, it will be specific to the dopamine receptor. Moderate therapeutic dose, it will be effective on the dopamine and beta 1 receptor. For a very high dosage of the dopamine, it will be effective on alpha 1, beta 1, and dopamine receptors. So at three different levels, three different doses, at each dose or level of the dosage, it will result in activation of different receptor. Low dose, dopamine receptor. Moderate dose, dopamine and beta 1. High dose, alpha 1, beta 1, dopamine receptors. Therapeutic uses will be very effective in shock because it will increase cardiac output and it will increase renal perfusion. Kidney perfusion will improve. So that will treat shock in which that there is a significant decline in perfusion to the vital organs, heart, brain, kidneys, liver. So in shock, the dopamine will be very effective drug because it will increase cardiac output and it will increase kidney or renal perfusion. In heart failure also, it will increase myocardial contractility. And it's an positive inotropic medication because it increases the strength of contraction of the myocardium. Acute renal failure. Also, this drug or dopamine will be effective in treating patients with acute kidney injury or kidney renal failure, acute phase. Adverse effects, tachycardia, dysrhythmia, inguinal pain, which is an angina pectoris, necrosis, and extravasation of the drug. Usually the drug is diluted, and this is the recommended dosage, which is 2 to 5 micrograms per kg or kilograms per minute. And the max dosage for the dopamine would be 20 micrograms per kilogram per minute. Dobutamine, which is formerly known as Dubutrex, it's a specific to the beta 1 receptor. And it's very effective in heart failure. It may cause, or which is adverse effect of such as a tachycardia, and it may interact with MAO inhibitors, TCAs, or tricyclic antidepressants, and certain general anesthetics. So it should be given as a continuous IV infusion, and this is the recommended dosage for dobutamine, which is 2.5 up to 10 micrograms per kilogram per minute. Trobuline, it's a tocolytic drug, and this is a very important concept here. Tocolytic drugs, which is anti-contraction medications or labor suppressants, they can suppress and stop labor. So the tocolytic agents are medications, drugs that are given during the preterm labor to prolong the pregnancy for at least 48 hours to enable the administration of the antenatal corticosteroids, magnesium sulfate, or to buy kind of more time for maternal transport to the tertiary care facility. So the tocolytics, they have been shown to improve infant morbidity and mortality rates, and they also can be called the anti-contraction medications or labor suppressants to stop labor and to prolong pregnancy for at least 48 hours to enable the administration of certain medications like corticosteroids, magnesium sulfate. So it's a beta 2 agonist, and it's very selective for beta 2. So it can be given or prescribed for asthma. So this drug, terbutaline, had replaced the azaprotinol in treatment. Also, it's effective to delay preterm labor because it will relax the uterine smooth muscle. And there was another drug that was removed from the market by the FDA, which is the Rytodran. Rytodran was removed from the market by the FDA. Adverse effects, minimal therapeutic doses. So terbutaline should not be used to treat preterm labor that has already lasted more than 48 to 72 hours. And we always have to benefit or measure or weigh the benefits of this medication with its risks. So risk-benefit ratio should always be considered whenever we prescribe the terbutaline. So commonly used tocolytic medications include like beta 2 agonists. They are tocolytic medications. So calcium channel blockers also, they are tocolytic medications. NSAIDs, magnesium sulfate, they all can be labeled as tocolytic medications. Beta 2 agonist, like terbutaline, calcium channel blockers, which is a CCB, which is anti-hypertensive drugs, the NSAIDs, which is non-steroidal anti-inflammatory drugs, and magnesium sulfate, the mag sulfate. All these four categories can be listed or can result in a tocolytic effect. And again, we said that tocolytic is the anti-contraction medication, or what is called liver suppressant, in which that they are given to women in preterm labor to prolong pregnancy for at least 48 hours to enable for the administration of antenatal corticosteroids, magnesium sulfate, or by some time for maternal transport to another facility. So the tocolytic has been shown to improve, we said, the infant morbidity and mortality rates. So terbutaline, again, should not be used to treat preterm labor that has already lasted for more than 48 to 72 hours. And also said that the benefits of terbutaline must always be weighed up against its risks, as serious and sometimes fatal side effects have been reported after the use of terbutaline in pregnant women. Now, the adrenergic blocking agents, what is called the beta blockers, beta antagonists, beta inhibitors, it's the same. Adrenergic blocking agents, beta blockers, or antagonist, or it can be alpha or beta actually. It's adrenergic. When we say adrenergic blocking, means alpha blockers or beta blockers. Alpha inhibitors or beta inhibitors, both alpha and beta receptors. So adrenergic is both alpha and beta receptors. So alpha adrenergic blockers, it should include both alpha adrenergic blocking agents, alpha blockers, or beta adrenergic blocking agents, which is beta blockers, alpha inhibitors or beta inhibitors, alpha blockers and beta blockers. So the first drug or the prototype drug here is prazosin, minipress, to inhibit the sympathetic nervous system. And its primary use is hypertension, dysrhythmias, angina, heart failure, BPH, glaucoma, especially the narrow angle glaucoma. Side effects would be dizziness, drowsiness, headache, loss of energy and strength, palpitations, dry mouth. So prazosin, which is the minipress, it's a selective alpha-1 adrenergic antagonist, alpha-1 blocker, that competes with the norepinephrine at its receptors on vascular smooth muscle in arterioles and veins. So it will result in the vasodilatation. So it's an antihypertensive drug because it will result in vasodilatation. So the prazosin, minipress, it's a selective alpha-1 adrenergic antagonist that will compete with the, or antagonize or inhibit the norepinephrine at the receptors on the vascular smooth muscle in arterioles and veins. So it will result, in other words, the ultimate goal is to dilate the blood vessels because of this inhibition on the receptor of the blood vessels of alpha-1 receptor. So it will result in vasodilatation, and it will decrease the blood pressure, so it will manage the hypertension. So it's an antihypertensive drug. So its major action is rapid decrease in peripheral resistance and reduces blood pressure. It will have a little effect, very small effect on cardiac output or heart rate. It may cause or result in less reflex tachycardia than other medications in the same class. So the most important effect is that it will decrease the blood pressure and control hypertension. So we have other medications belong to the same class of alpha-1 blocking drugs or alpha-1 inhibitors or blockers like alphazocine, atenolol. These are the beta. Atenolol is beta 1 antagonist. But the alpha-1 only, we have very few, like the prazosin, which is minipress, it's alpha-1 blocker. The doxazosin or Dura also, it's an alpha-1 blocker, and it's effective for hypertension and benign prostate hyperplasia. Another alpha-1 is alphozocin, but doxazosin is more commonly used than the alphozocin. And the rest of the medications are beta blockers, but some of them also, they are beta and alpha blockers. For example, we have carvedilol. Carvedilol is an alpha and beta blocker. It blocks both receptors. Carvedilol blocks alpha-1 and beta-2 and beta-1 and beta-2. So carvedilol blocks alpha-1, beta-1, and beta-2 receptors. And it's very effective antihypertensive drug. And also it's effective for heart failure and for acute MI. Atenolol is the beta blocker, but it's very selective to the beta-1 receptor. So It's very effective for hypertension and angina. Metoprolol, same thing. It's a beta-1 blocker. Depressor, Toprol. Metoprolol, generic name. Lopressor or Toprol, brand name or brand name, which is beta-1 blocker. Also, it's the or inhibitor, which is indicated for hypertension, acute MI, or heart failure. So the adrenergics, so just going back to the list of medications in which that we have the drugs either it will block the beta or alpha receptor, except for just two medications. Here we have one is listed in this table, and there's another medication called labetalol. Labetalol, which is like carvedilol, blocks both alpha and beta receptors. Carvedilol, correct, and labetalol, Labetalol. These two medications, they block both alpha and beta receptors, and they are anti-hypertensive medications. These are some of the therapeutic applications of alpha blockade or alpha blockers. Essential hypertension, benign prostate hyperplasia, pheochromocytoma, which is a in pathophysiology or in the pathophysiology section, will explain the how the pheochromocytoma develops in terms of that it's a disease. Most of the time, it's usually results from that tumor at the adrenal glands. The adrenal gland tumor will release catecholamines, and these catecholamines, like epi and norepinephrine, that will increase the blood pressure. So that will result in extremely high blood pressure, headache, perspirations, sweating as the most prominent signs or manifestations and signs and symptoms. Raynaud's disease, which is a peripheral vascular disorder. Now, Rigetine or phentylamine, it's a non-selective alpha adrenergic antagonist, and it's usually used for the treatment of hypertension and hypertensive emergencies. It can be also is effective drug for pheochromocytoma. In also patients with a vasospasm of Raynaud's disease or frostbite. Phentylamine Rigetine also is an effective drug for clonidine withdrawal effect or syndrome. So patients on clonidine, which is an alpha receptor agonist, but centrally acting alpha-1 agonist, which is an antihypertensive drug, clonidine. But patients on clonidine, sometimes they develop a clonidine withdrawal syndrome. When we abruptly stop clonidine, they may end up with clonidine withdrawal syndrome. Phentylamine Rigetine is a very effective drug for clonidine withdrawal syndrome. Phentylamine or Rigetine can be effective for impotence and for peripheral vascular disease, PVD, like Raynaud's disease, also very effective for vasospasm of Raynaud's disease or frostbite. But remember also about the phentylamine, it can cause orthostatic hypotension, reflex tachycardia, nasal congestion, and the overdose can produce profound hypotension, significant or severe decline or decreased blood pressure. So therapeutic applications of beta blockade or beta blockers. These are the therapeutic applications and indications like angina pectoris, hypertension, and the mechanism, which is decreased cardiac output and decreased renin from the kidneys, cardiac dysrhythmias, myocardial infarction, heart failure, hyperthyroidism, migraine. It can be used as prophylaxis, stage fright, pheochromocytoma, and glaucoma. Now, the adverse effects of the beta-1 blockade, beta-1 blockers, bradycardia. So if necessary, can be given with atropine, for example. Can be with atropine, because atropine will increase the heart rate. It can result in reduced cardiac output, decreased cardiac output. So the beta blockers must be given with the great caution in patients with CHF, heart failure, or decreased cardiac reserve. Bronchoconstriction. So contraindicated for people with asthma or COPD because beta blockers result in bronchoconstriction. So it shouldn't be prescribed. So it's contraindicated in patients with asthma or COPD. Also, inhibition of glycogenolysis, such could be also contraindicated for patients with diabetes because the beta-1 blockers or inhibitors, they will mask the signs and symptoms of hypoglycemia. So patients may end up with, they are not going to be, exhibit or will be presented with the early signs of hypoglycemia. They may go into direct, like that, right to the hypoglycemic shock and coma before having all the symptoms of hypoglycemia, like perspiration, the climb scan, or the confusion, or the general weakness, or fatigue, or all of these are early signs of hypoglycemia, but patients may end up too right to the hypoglycemic shock, and due to this inhibition of the glycogenolysis. So that's why it's contraindicated in patients with asthma and COPD, and contraindicated in patients with diabetes because of these two expected side effects or adverse effects of the beta blockers. So here we have a beta blockers, examples, medications, receptors, effect, and then the primary use. So we have a first, second, and third generation of the drugs. For example, the first generation, which is the non-selective beta blockers, they are drugs, medications going to block the beta-1 and beta-2 receptors like propranolol, Inderal. Propranolol, Inderal, that's a beta-1 and beta-2 receptor antagonist or inhibitor or blockers. And it's very effective in patients with hyperthyroidism because it will treat or stop the palpitations, tachycardia. That's the first generation, which is non-selective beta blockers like the propranolol. Second generation, which is cardioselective beta blockers. It will block the beta-1 receptors, like metoprolol, an example of that. Metoprolol, Lopressor. The third generation, which is the vasodilating beta blockers. They block alpha 1, beta 1, and beta 2, like carvedilol. Correct. And these three medications can be found in the previous slides or previous table. So what common or widely used medications would be the phentylamine, Regitine, Prazosin, Propranolol, Tamsulosin, which is Flomax, which is an alpha-1 blocker to treat the benign prostate hyperplasia, and Timolol for hypertension, acute myocardial glaucoma. All right, so this concludes the lecture on chapter 13.